free living amoebas or opportunistic amoebas. Again, as an overview of what we already did when we're talking about Interamoeba histolytica, when you're talking about parasitology, you can divide it into looking at protozoa, looking at worms, which we call helminths, and also looking at bigger things, insects, we call them arthropods. Okay, these are vectors of disease. They carry the small parasites that are going to cause infection. For example, a fly, a mosquito, those are arthropods. They are vectors. They carry the actual parasites. For example, the mosquito can carry the malaria parasite, which we call plasmodium parasite. So on the protozoa, we can classify them into two main groups, the apicomplexa and the sarcomastogophora. The apicomplexa will talk about plasmodium. This is the guy that is going to cause malaria. Babesia, which causes what we call babesiosis, and then Toxoplasma gondii, which causes what we call toxoplasmosis. Each one of these is a topic. I think after today's class, we'll now start talking about toxoplasmosis or babesiosis. And then Sarcomastogophora, we have got two. We have got these guys that live in, these which have got flagella. So we call them flagellates. And then amoeba. Amoeba do not have flagella. These are a type of protozoa that do not have flagella. For those which have got flagella, you can have those that are found in blood. We call them hemoflagellates. And then those which are found in the intestines, we call them intestinal flagellates. The hemoflagellates, we have got leishmania and trypanosomes. Leishmania causes what we call leishmaniosis. Trypanosomes causes trypanosomiasis. And then the intestinal, we have got Giardia lamblia. And this one will cause what we call giardiasis. Now, the amoeba, which do not have flagella, we have got those which are found in the intestine, actually pathogenic, they cause disease, but not all of them. Most of them actually don't cause disease except Interamoeba histolytica, which we already discussed. It's the only intestinal amoeba that is pathogenic, which causes disease. The other amoebas are free living. They are opportunistic. All free living amoebas are opportunistic parasites. They can only cause infection when they find a privilege. For example, Nargleria fowleri, acanthamoeba, and Balamonthia. So these three, they are free living, opportunistic amoebas. When you're talking about whatsoever we talk about in microbiology, you're supposed to understand the morphology of that parasite, the life cycle, the pathogenesis, how does it cause disease, and what are the clinical presentation and clinical features of that disease? How can you confirm that someone has got that disease? Laboratory diagnosis. How do you treat that, and how can you prevent? This is the overview for nearly all the topics in microbiology. So when we are talking about the opportunistic parasites or these free living parasites, they are going to cause three infections, or three actually. So for Nargleria fowleri, this one causes what we call primary amoebic meningoencephalitis. You can see meningo, meaning it is affecting the meninges, dura mater, pia mater, arachnoid mater. Encephalitis is inflammation of the brain. Meningo, it is the meninges. The meninges are the coverings of the brain. So when you're talking about infections of the central nervous system, you can have meningitis and encephalitis. Meningitis, everything that ends in itis is inflammation. Meningitis, inflammation of the meninges. Encephalitis is the inflammation of the actual brain. But this is a combination. There's going to be inflammation of the brain and also the meninges, or meningoencephalitis caused by amoeba. So primary amoebic meningoencephalitis, PAM. That is caused by who? The amoeboflagellate Nargleria fowleri. Nargleria fowleri is known as a brain-eating amoeba. Just go on YouTube and type brain-eating amoeba. You'll see. So this guy, we'll discuss it properly. Let me go. And then you also remember we talked about You've got Nargleria fowleri, you've got acanthamoeba and balamunthia. So the acanthamoeba, this one causes granulomatous amoebic encephalitis. Would you discuss this in pathology when it comes to inflammation? We have got what we call acute inflammation and chronic inflammation. Chronic inflammation most manifests as a glomatous form of lesion, like there's a granuloma formation. So granulomatous amoebic encephalitis and chronic amoebic keratitis. So acanthamoeba affects the brain and the eyes. Actually, do you know that of all the 12 cranial nerves, cranial nerve number 1 is the only one which is part of the brain? If you did talk about the development of cranial nerves or the development of central nervous system, you could find out that cranial nerve number 1 is actually part of the forebrain. It came from the forebrain. So most of the times, if someone has got, let's say, the accumulation of fluid in the head, they're also going to have the accumulation of this fluid also on around the cranial nerve number. That's cranial nerve number 2, isn't it? And then it will end up impinging on the cranial nerve, and that can cause blindness. So take note of these two conditions. Balamunthia can also cause granulomatous amoebic encephalitis. Please take note which one causes which. It's very easy. Okay. So primary amoebic, sorry, the PAM, that's primary amoebic meningoencephalitis, and the chronic amoebic keratitis. These ones can occur in also people that are healthy. But the granulomatous amoebic encephalitis has been associated with those people that are immunodeficient. For example, someone is already sick, maybe they have got HIV, but these two can occur even in the health people. So let's begin with Nargleria fowleri. Nargleria fowleri, this guy is the only species of the genus Nargleria which infects man. It's the only species, the fowleri. And it causes primary amoebic meningoencephalitis, which is a brain infection that leads to the destruction of the brain tissue. Worldwide, of course. Where do we find Nargleria fowleri? It's mostly found in warm, fresh water. You see, this is warm, not the cold. Warm, fresh water, for example, in the lakes, in the rivers, in the springs. So you are going to see why, how we can get it. It's because of where it's found. Like, for example, in the river, someone is swimming, like us, the way we used to swim when we were children. Fowleri, Nargleria fowleri is also found in the soil, not just in fresh water. Take note that it is a heat-loving amoeba. It is thermophilic. So where there is high temperatures, it loves that place. That's why it's found in warm, fresh water and also in the soil. It is going to thrive in warm water even at low oxygen tension. So reduce oxygen, you not kill the bro. It will still be there. Of course, not a lot of infections have been reported, and mostly maybe because of lack of proper instruments to be able to detect these, or maybe just negligence from the health sector on trying to really find out if the infections are still prevalent. That's why you can see the reported cases being low. So, for the fact that cases are low does not mean that it's not there. Now, on the morphology, we talked about the morphology of Entamoeba histolytica. Also, we said that there is the cyst, the pre-cyst, and also what was the other one? So the cyst, the pre-cyst, and the trophozoid. Please don't forget. And then for the morphology of Nargleria fowleri, you have got three forms. You have got the cyst and the trophozoid, but the trophozoid is in two forms: amoeboid form and the flagellate form. So there is the form that looks like an amoeba, like it doesn't have flagella, and then the form that looks as though it has flagella. So we say the amoeboid, trophozoid, and the flagellate, trophozoid, and then the cyst. Oh, take note of this. This is what makes microbiology a bit tricky because you have got shapes for each one of them, and you're supposed to know for each one of them. So if you look at the amoeboid trophozoite, it has got rounded pseudopodia, which we call lobopodium. That's important, please. The amoeboid. Remember, this is the amoeboid. It's like an amoeba. An amoeba doesn't have flagellates, but it has got pseudopodia. Pseudopodia, these are like hands that these guys used to engulf, right? You can see these things that are bit like coming out from there. That's a lobopodia or the pseudopodia. And then it has got a spherical nucleus inside, and then a pulsating vacuole. A pulsating vacuole is used to engulf the red blood cells and the white blood cells. Please take note, this is a pulsating vacuole, not a food vacuole, because in multiple choice questions that can come. Pulsating vacuole to engulf these cells, the red cells and the white cells. How does this? So the amoeboid trophozoite form is a form that the bacteria is going to be using for, sorry, not the bacteria, but the parasite is going to be using to feed, to grow, and to replicate. So this is the form in which it does these three things. And this is the form that you are going to be able to see on the surface of vegetation, mud, and water. Okay. And take note that it is an invasive stage. Invasive stage means the stage that can penetrate through the body. For example, if it goes into your GIT, it can penetrate through your GIT to go into your blood and go to through the rest of the body. And it's also the infective form. Infective form is a form that causes disease. So the amoeboid trophozoite is a form that will cause infection, and it's the one that will be able to penetrate the body. And take note that it's the only form that is found in the cerebrospinal fluid. Remember we said that Naegleria fowleri causes infection of the central nervous system, but of the three forms, only the amoeboid form can be found in the cerebrospinal fluid. When you look at the flagellate trophozoite form, this one is pear shaped. You can see even here the way it's looking, this one down. And it has got two flagella. You can see these two that are coming out. And it's found in surface layer of the water, on the surface layer of the water, not on vegetations like the amoeboid form. And this form is transient, like it doesn't waste too much time in the flagellate form. It's transient, and it is rapidly motile. It does move, and it's actually this form that helps the amoeba to be able to spread to new water bodies. It is in this form because that's got flagella. It can move. Take note that this form is not found in the central nervous system. It's only the amoeboid form that is found in the central nervous system. And then for the cyst, which is this one that we can see on top, the cyst is the, just like we talked about in Amoeba histolytica, the cyst is the resting stage. The cyst doesn't move, it's the resting stage. Another important thing you need to know about cysts, most of them, is that they are resistant to unfavorable conditions. That is why when the conditions become bad for the parasite, they are going to change shape and become a cyst. And that's known as the encystment or encystization. And then when they change from a cyst into another form, that is known as excystization. EX. Encystization is EN. Okay. So this form, the cyst, is resistant to drying and to chlorine. So meaning that, let's say for example, you go to water and you want to treat it from all these parasites and these microorganisms. If you have got Naegleria already there, you use chlorine. It will not do anything because chlorine can't treat this. Instead, you can use that's iodine. So that's an exam question also. It has got a smooth double cyst wall. Please take note, it is a double cyst wall. It's not only one, but two. The trophozoites can insist. Remember what we said? When something changes into the cyst, that is known as insist. When the conditions become bad, trophozoites can't survive. So they have to change into something that can be able to survive that condition. So they are going to insist. For example, if there is no food, food deprivation, desiccation, or the cold temperatures, because we said that these guys survive in warm environments. Take note that they are nucleated, only one nucleus, and possess a double cyst wall, and they are found on the surface of vegetation and mud. Okay, just like the amoeboid trophozoite. And the cyst, just like the flagellate form, specifically the flagellate of the trophozoite, these are not found in cerebrospinal fluid. It's only the amoeboid form that is found in cerebrospinal fluid. But now, what is the life cycle? How does this change? You can see even from the picture here. Infection with Naegleria fowleri is going to occur when swimming or diving in warm river, fresh water, or ponds. It can also occur in poorly maintained swimming pools or during nasal irrigation. Nasal irrigation is a process where trying to cleanse your nose using the water, and the water specifically is coming from the tap. It's contaminated. And the way this happens is because Naegleria fowleri causes infection by penetrating through the nose. I'll mention that. So the amoeboid form, remember we said that is the infective stage to man, and it multiplies by binary fission. Please, not fusion, fission. You can find, especially if they've given you true or false questions, they put fusion there. You say, oh, this is correct. No, it's fission. Fission is breaking one the middle to form two. Fusion is two coming together to form one. So under when the conditions become unfavorable, there's going to be incystization, the formation of the cyst. And when the conditions are now favorable, the cyst will form the other forms like the trophozoite, and that's known as excystization. The soil amoeba gets transformed to temporarily non-feeding flagellate. We said, remember, like the trophozoite that has got the amoeboid form and the flagellate. And the flagellate, to be specific, is only transient. It's not forever, just to help in moving. Flagellates form of the trophozoite help in the spread, as we said already, to new water bodies. The completion of the life cycle occurs in the external environment. This is important. You can also find that as a multiple choice. You can see the cyst can change into an amoeboid form. The amoeboid form can change into the flagellate form. The life cycle can complete without using another host. Just outside on the external environment, it can be constantly undergo all these processes. So how does man acquire the infection? You can see this dude here is trying to do some exercise in the water, and then you have got the flagellate form, which is the form that moves. Flagellate form and the amoeboid form, these are the two forms of the trophozoite. They mostly exist together. There is the like co-transformation, so we call it the amoeboflagellate. So these guys, the amoeba, that's the infective form, and the invasive form can enter through the nose when someone is swimming. At the same time, the amoeboid form can convert to the cyst. The cyst can still convert back to the amoeboid form of the trophozoite. So that is what happens. And how do these guys cause disease? Pathogenicity. So patiently are mostly previously healthy young adults or children, because they're the ones that like swimming. Unless maybe you are dating and you took someone to a swimming pool which is dirty. So infection occurs following swimming or diving in ponds which contain amoeba, and that is going to initiate an acute purulent meningitis and encephalitis called primary amoebic meningoencephalitis. So you can see there is the inflammation of both the meninges and the brain encephalitis. So the first thing that happens is that someone is swimming or diving in ponds containing amoeboid form. The amoeboid invades the nasal mucosa, passing through the cribriform plate, and then through the cribriform plate is going to go through olfactory nerve, which is cranial nerve number 1, and then it will go and reach the meninges and the brain, causing the primary amoebic meningoencephalitis. Did I include a picture? I didn't include a picture. But we did discuss this when we were talking about head and neck. We talked about the ethmoid bone. We said that the ethmoid bone has got small openings. On top, we have got what we call crista galli of the ethmoid bone. And on the sides, we have got a lot of openings, the foramina of the cribriform plate. And that is where cranial nerve number 1 passes from the nose connecting to the brain. And this is where Naegleria fowleri will be able to pass. Please review head and neck if you can't relate to what I'm saying. So if someone has got this disease, how do they present? How are you going to know that, okay, this one has got primary amoebic meningoencephalitis caused by Naegleria fowleri? The disease advances rapidly, causing the bifrontal or bitemporal headache. You know, frontal bone is the bone that is in front on your forehead. So, like you're having a headache both on the left and on the right, or on the temporal bones, both on the left and on the right. So, there's going to be headache, there's going to be high fever, stiff neck. Stiff neck is a sign for meningitis, the inflammation of the meninges. Ataxia. Ataxia, this is where someone is uncoordinated, like there's incoordination. When you're walking as though you are drunk, like that, with some steps which are confused. There can also be seizures and can lead to a coma. These are early and they can be followed by nausea, vomiting, irritability, and restlessness. You can't just sit like just restless. The incubation period is a period from the time of infection till you start seeing from the time when this parasite enters the body to the time when you start seeing the manifestations. Normally it takes 2 days to 2 weeks. So you can have manifestations 2 days from the time you got the infection, or even 2 weeks later. And in this period, the patient is going to experience anosmia, like there is loss of smell, because remember, this is affecting cranial nerve number one. There can also be cranial nerve pulses, especially cranial nerve number three, number four, and number six. This can have pulse. A pulse is where, so these nerves, the parts that they're supposed to control, the parts that they're supposed to innervate. Cranial nerve number three, number four, and number six, these nerves control the movement of the eye. Okay, we call them, these are ocular nerves. They control the eye movement. So if there is a pulse for these cranial nerves, this is where there is a disturbance in the way they'll be able to move their eyes, so they barely can't do that. There will also be photophobia, which can occur later on, and also neurological abnormalities, problems with the nerves, including lethargy, seizures, confusion, coma, diplopia, seeing double vision, or bizarre behavior. Someone just comes and says, I am seeing a cat, a cat is fighting with a tree. This cat is fighting with this tree. So that is bizarre behavior. And actually, in neurosciences, you're going to find out that that is one sign of psychosis. Ukupena. Someone is getting, is getting insane. Yeah, bizarre behavior. No, someone is talking to me. So this can lead to death within a week. It's very bad. The disease almost always ends up fatal within a week, average 5 days. So if someone gets Negrella for real, within 5 days they are gone. This is how bad it is. Okay. So if someone has got primary amoebic encephalitis caused by Negrella for real, how can you confirm it? You can perform some microscopy where you are going to get the freshly obtained cerebrospinal fluid. And remember, for cerebrospinal fluid, you are trying to look at the amoeboid form, and you can look at it on the microscope when you have stained the smear with James stain, right? And then the CS picture resembles that of bacterial meningitis. So if someone has got meningitis caused by bacteria, there is going to be accumulation of the white blood cells that is going to cause a cloud to purulent appearance. And then there's a prominent neutrophilic leukocytosis. Leuko is representing white blood cells. Cytosis is increase in number of cells. So this is an increase in the number of white blood cells. This is a characteristic feature of meningitis caused by bacteria. So same way with this primary amoebic meningoencephalitis, there's also this feature. There's also elevated proteins and low glucose. These are actually features for bacterial meningitis. Opposite, if the meningitis is caused by viruses, you will not be able to see the increase in the the cloudy appearance, because you don't have the white blood cells accumulating. And then on autopsy, when someone is gone, and then now you get a sample of their brain or something, you are going to see the brain histologically being demonstrated by this immunofluorescent staining. So you'll be able to tell that, okay, this one had meningoencephalitis. You can also culture the parasite. Culture is growing it so that when it grows, and then you can be able to identify properly. And in culture, both the trophozoite and the cyst can occur. Molecular diagnosis, like the PCR, can as well be used to diagnose this condition. So molecular diagnosis is now where you are looking at you go a bit deeper to the genetics. You look at now the part which is being affected, like the maybe the chromosomes being involved. And then the treatment here, you can use this drug, amphotericin B IV, like you inject it in the veins, or you can give it intrathecally, where you inject in the spinal cord. Remember that someone here can have meningitis, and the spinal cord is part of the central nervous system, so you can still inject there because the same cerebrospinal fluid which is present in around the brain is also present around the spinal cord. You can also give ketoconazole. Ketoconazole is an antifungal drug. It's used to treat fungal infections, but you can as well use it here. Azithromycin, semacrolide. Anyway, let me find if even be mentioning semacrolide. It will not make sense, but don't worry, you understand this will be your own. These drugs will be at your fingertips. So azithromycin is a macrolide. It's an antibiotic, a drug that you use to treat bacterial infections. So you can also use it. New drug also multifosin can be given. But if someone has got primary meningic encephalitis, 90% of the time is that they're going to die. Only 5% chance of that person getting better. So you can see how bad it is. Prevention and control, chlorination of heavily used swimming pools, especially during the summer months. Though we said that these guys are resistant to chlorine. In high-risk areas, monitoring and recreational water for Nargleria fowleri amoeba should be considered by local public health authorities and appropriate warning posts. So put a post there. You can say keep your head above water because these guys will be entering through your nose. So you can put those signs. So that's about Nargleria fowleri. And then acanthamoeba. Acanthamoeba species, of course, are a lot. Just like we said that the Nargleria species are a lot, but the only one of medical importance to human is the fowleri. Same with acanthamoeba. We have got acanthamoeba caubatsson, which was formerly known as Hartmanella caubatsson. This is the species most often responsible for infections that happen in human, and it causes infection of the eyes, the skin, and the central nervous system. Infection by other species, for example, acanthamoeba polyphagia, this one will cause corneal ulcer. Acanthamoeba castellane, acanthamoeba astromix, this can also cause infection. Just know acanthamoeba will cause these, especially the caubatsson, the main one, eye infection, skin, central nervous system. This one is also an opportunistic infection, doesn't usually cause infection unless conditions become better and is found in water and soil, just like Nargleria fowleri. Morphology, it has got a cyst and a trophozoite. Look at this. The trophozoite doesn't have the amoeboid form and the flagellate form. You just have the trophozoite there. So it is only in two forms. So you see now how the questions in microbiology, this is where they become tricky. You have got a lot of parasites to know, and then you can see the little differences between them, right? So these are the important things to take note of. The cyst is present in all types of environment all over the world, and the trophozoite is an active form. It is large, and it will replicate by mitosis, and it has got pseudopodia. The pseudopodia of acanthamoeba, we call it acanthapodia, and it is different from Nargleria because it doesn't have a flagellate stage. So meaning that this trophozoite is actually the amoeboid form, not the flagellate. It doesn't have flagella. And then the cyst is going to form in tissue. And we said that for Nargleria fowleri, the cyst can form even in the external environment. The life cycle, both the trophozoite and the cyst can cause infection. Differentiate from Nargleria where the amoeboid form was the one which was causing infection, which was the infective form. And then infection can occur by, you can either, if you inhale either the cyst or the trophozoite, or you ingest like through the food, you ingest the cyst, or contaminated with traumatized skin or eyes, abrasion of the cornea. Because we said that acanthamoeba is going to cause chronic keratitis, like there is inflammation of the cornea. So there are some people that you use contact lens which have been contaminated, and because of those they can actually get to contaminate your eyes, and then you get also the infection. So when the acanthamoeba species enter the eye, it can cause severe keratitis in even health people, especially those who are using contact lenses. And then if it goes via inhalation or through the respiratory system or through the skin, it can invade the central nervous system. So please take note of where it's going. The eye is mostly causing severe keratitis via the contact lens. Respiratory system and the skin, it will go to the central nervous system. Or it can go through blood. Actually, to go through, if it enters through the respiratory system and the skin, it is going to go now to the blood, and then it will be disseminated throughout the body, and that's when it will cause the granulomatous amoebic encephalitis, which is the infection of the central nervous system. Or it can cause disseminated disease. This is the disease that affects the entire body. Can cause skin lesions in individuals with who are compromised immune system. So you can see again here, the cyst can get to penetrate and cause infection. Even the amoeboid form can also get to cause infection. If the eye is involved, can you see someone that has got keratitis there, inflammation of the cornea? And then pathogenicity, how does this guy cause infection? Infection usually occurs in patients with immunodeficiency, someone that has got diabetes, someone that has got a cancer, malnutrition, and also someone that has got systemic lupus erythematosus. This is an inflammatory condition. So the parasite is going to spread hematogenously through the blood, and then it goes into the central nervous system. And then when there is invasion, the penetration of tissue, like to invade means to penetrate it. So if for whatever reason I ingest, like I eat something, that is not invasion. Microbiologically speaking, to invade means to penetrate through epithelium. So as long as you've not penetrated the epithelium, that's not invasion. So when there is invasion of the connective tissue and induction of pro-inflammatory response, this is going to lead to neuronal damage that can be fatal within days. And the postmortem biopsy is going to show severe edema and hemorrhagic necrosis. We talked about necrosis in pathology, right? We differentiated necrosis from apoptosis. We can also get to review that. So I've talked about three main ways through which you can get infection by acanthamoeba: inhalational, you can also get it through ingestion, and also through the contact lenses. The clinical features, this one causes two conditions, and these are chronic conditions for over a long period of time: granulomatous amoebic encephalitis and acanthamoeba keratitis or chronic keratitis. You can see for the acanthamoeba keratitis, this is a contact lens that this person is using. Okay, they put it like on the eye and then so that they can be able to see properly. But imagine this one has been infected with the same acanthamoeba, so that is going to now result in this condition. So some features of this condition will be unilateral photophobia, like one side, a patient can't accommodate light, excess production of tear, redness, and foreign body sensations. Like you just feel like there's something in the eye, so you'll be scratching very much, and of course that can contribute to the redness of the eye. And then, so keratitis and uveitis can result in permanent visual impairment. So someone will just stop seeing. Uveitis is the inflammation of what we call the uveal tract. So there is one layer of the eye where I've got the ciliary body. So all these, they will be inflamed. That's the uveal tract. Granulomatous amoebic encephalitis, it is a serious CNS infection. Of course, central nervous system is the brain and spinal cord, so both of them are going to be affected, especially in the immunocompromised. And this one is normally believed to follow inhalation of the dried cyst. The incubation period is long with a slow evolution of the illness. That's why these are chronic conditions because they happen over a long period of time. The clinical picture is that of intracranial space occupying lesion with seizure, like as though there is something that is taking up your space in the brain. Because the way the skull is that there is no space for expansion. So anything that takes up any space in the skull, what that does is that it is going to compress on the brain, and any compression on the brain, depending with which area of the brain has been compressed. Let's say, for example, you've compressed somewhere on the parietal temporal bone this side where you have got, say, the Wernicke's area. That helps us in understanding. It means that if someone is speaking, you can't understand anything. Let's say, for example, the space occupying lesion has occupied somewhere in front, somewhere the frontal lobe, and then you have compressed on what we call the Broca's area that helps us in speaking. It means that you can't speak. So depending on which area of the brain has been affected, of course, it can manifest in different ways, and it will include seizures, paresis, and mental deterioration. So someone can't think properly. There is an raised intracranial pressure also. Disseminated infection can occur, especially in the immunocompromised, like those that have got systemic lupus erythematosus, TB, and AIDS. Infection can as well get to spread to other parts of the body, the skin, the lungs, the sinuses, in the skull, and other organs, depending independently or in combination can occur. So it can be bad. How can you diagnose someone that has got these conditions? For someone that has got amoebic keratitis, you'll be able to look at the cyst in the cornea scraping on wet mount. So you get to have a scrap on the cornea, and then you'll be able to see the cyst. And then you can also, to diagnose granulomatous amoebic encephalitis, you can demonstrate the trophozoite and the cyst in the brain biopsy because this one is specifically affecting the brain. So you get a sample from the part that has been affected. You can also perform culture and then immunofluorescence microscopy using monoclonal antibodies. The IgEs, the IgMs, those are what we call monoclonal antibodies. The cerebrospinal fluid is going to show lymphocytic preocytosis. There's going to be a raised blood cell count in cerebrospinal fluid. More the white blood cells are going to be raised. The proteins are also going to be a little bit raised, and glucose can either be normal or a bit decreased. And these are some features of inflammation of the meninges, like meningitis. But this one, of course, not really affecting the meninges. That's why we're saying it is encephalitis affecting the brain itself. The CT scan of the brain can also provide some data, but it's inconclusive. You'll not be able to tell what's really the main thing. And then the treatment for this condition, you can use topical administration of biguanide or chlorhexidine. So this one is topical, like you're applying at the place where there's a problem. For example, if someone has got a problem on the eye, right? Apply just on the eye. In severe cases where vision is threatened, penetrating keratoplasty or optical penetrating keratoplasty can be done. But forget about that, right? It's not for you for now. So no effective treatment is there for granulomatous amoebic encephalitis. So if someone has got the infection, more likely we are waiting to bury them. But you can give some pentamidine, sulfadiazine, rifampicin, fluconazole. These are actually antifungals like this, the fluconazole, treating fungal infections. These are some things that you can just say, okay, but don't worry much about this slide about the drug. Just know that granulomatous amoebic encephalitis is very hard to treat. Prevention and control: kill the antamoeba species from the contact lenses before you can put on your eye. And then the tap water should not be used to rinse contact lenses because they can contain the amoeba. So that is it. And I've got some questions for you to be able to try out. We'll see if you can answer them on Entamoeba histolytica, acanthamoeba, Nargleria fowleri, and Balamonthia. So I'm going to send these questions. You try them out. We see. You can see even essays coming. List the morphological characteristics of Nargleria fowleri in comparison to acanthamoeba. Briefly describe hepatic amoebiasis. Explain the role of small intestine in the pathogenesis of Entamoeba histolytica infection. You can see how the questions can come there.